Thank you very much. Thank you very much for your presentation, Dr. Manten. And we are at the end of one of the most important sessions. Why? Because we know that all of us, at least the majority of us, look at the fetal brain in the second trimester. And let's have a look at the question now. And the first two are essentially for me. And the first one, how the presence or absence of ventriculomegaly in the second trimester influences the prognosis for corpus callosum anomalies? And it's a difficult one because, of course, so let's refer for complete agenesis of corpus callosum, which is the most common clinical scenario we might face. And I would say logically, it can influence the prognosis because there are several, I would say, small studies which says that severe ventricular megaly in conjunction with the agenesis of the corpus callosum may increase the risk of having an abnormal outcome. And first, I would like to say that actually saying an abnormal outcome does not mean anything, because when we ideally, at least what happened in pediatric neurology, when we report an outcome to a parents, we should at least detail the outcome. So there are studies which says that if we have severe ventriculomegaly, the outcome is worse. But why should we have severe ventriculomegaly? It most of the time is not because of an obstruction. It might be because of a severe cortical anomaly, which may translate as also ventriculomegaly. So in this case, it's not the ventriculomegaly per se, which influences, but rather the presence of the anomalous cortical surface, which I want to stress the concept that in order to give an accurate prognosis for this baby, so we cannot do that in the second trimester. We have to wait at least the third trimester in order to look at how the cortical surface of the brain develops. But there are other studies which say the opposite, in the sense that that baby with severe ventriculomegaly, because of course I know that most of you knows that in the third trimester there is a progressive increase in ventricular size even in fetuses with isolated ACC, and there are some papers essentially published, so essentially focus on postnatal outcomes, so there are pediatric series which do not report the presence of ventriculomegaly as an additional risk factors. So this is why I would just not say, so does the presence of ventriculomegaly affect the outcome, but just I would change the question is, does the severity and the cause of ventriculomegaly may affect the outcome? And the answer is essentially yes, when the ventriculomegaly is very severe. And I would say also yes, when the ventricular is not just the condition per se, but rather a sign of a cortical anomaly. So in this scenario, we have always to look at the cortical surface of the fetal brain. And I don't know whether the other people from the panel want to add something to what I said. Okay, so
yeah. Let me just ask a question, because I think that the clinical presentation is second trimester suspected agenesis of corpus callosum. They don't see the cavum septum pellucidum, and you have the referral. And I really think of course, when you look at the literature, and you've done that beautifully, where you presented the features, the associated or the ultrasound features of agenesis of corpus callosum. I think the truth is that the appearance varies with gestation. So I think sometimes what you see at 20 weeks is different from what you see at 36 weeks, even with the same condition of agenesis of corpus callosum, correct? So the teardrop sign, for example, which is something that I think we see more in the second at 20 weeks, I think is rarely seen at the end of the pregnancy. I think now we're doing routine third trimester scans, so we're doing scans late in pregnancy. We're seeing that actually the appearance of some of the abnormalities differ. So I guess when you counsel the patient in the second trimester, and when you have a mild ventriculomegaly, if you don't, the presence or absence of this mild ventriculomegaly, does it actually differ? Does it affect your prognosis? I mean, of course, if you have severe ventriculomegaly, that's a different scenario, because you do have almost two pathologies. But there's just the fact that and often it's mild, is it? It's a mild ventriculomegaly. Does it make a difference in terms of the counseling for the patient and the association with genetic abnormalities?
No, so not at all to me, because what has been widely reported, either pre and postnatally. Because it's not ventriculomegaly, so that sign is the rearrangement of the posterior part of the lateral ventricles. It's not just ventriculomegaly per se. So we might call it ventriculomegaly, but it's something different. It's part of the developmental scenarios of callosal agenesis, so complete callosal agenesis. which might be difficult perhaps. So it might be different perhaps in partial agenesis of corpus callosum, in which colpocephaly is not a striking site, is not a common site. It might be present. It depends upon how much of the corpus callosum is lacking.
Okay, fantastic. The one thing that I personally struggle with, and I suspect many people do, is this septo-optic dysplasia, and how do we actually counsel the patients, and how much investigations do you actually pursue in order to try to make a diagnosis, and how can you communicate this degree of uncertainty to the parents? And I mean, it's an open question to all the panels. I think something that I struggle with. Do you do estradiol, for example? Some centers would do estradiol level. Do you do that? Do you go that far, or do you just stop at doing the MRI and the genetic testing?
Asma, that's a very important question. I think that the primary diagnosis is a genesis or absence of septal pellucidity, not septo-optic dysplasia as such. And based on the finding, there is a 1 in 4 risk of septo-optic dysplasia being diagnosed postnatally. And we well know that MRI cannot assure us or parents that the optic nerves are present, absent, and the function of the optic nerves is, more importantly, we cannot assess it. So I would say 25% risk of child being blind after birth.
So yeah,
carry on, please.
Yeah, it's okay. So it depends. So it depends on how we consider it. So I agree, but prospectively is so we might have different clinical scenarios. The first one is that we see the fused frontal lobes with cavum septi pellucidi. We should also, we have to look at the parasagittal view of the fetal brain in order to identify schizencephaly. If we have cleft in the brain, the diagnosis is done. So it's easy, because in some cases, septo-optic dysplasia, the so-called septo-optic dysplasia, is associated with schizencephaly. In this case, the counseling might be easy because, of course, we see an associated anomaly. Of course, in the case we cannot see anything, it is not possible. It is not possible prenatally. There are several papers actually reporting the use of doing amnio and look at the hormones of the so looking at the hypopituitarism. But even in this case, it's not always so. There is not always a direct association at the time of the second trimester diagnosis. So what I think, if you have to say what I say clinically in clinical practice, is that it's not possible at that time to confidently rule out septo-optic dysplasia, because signs might appear only later on in gestation, or, as occurs in most of the cases, at birth.
Okay, and if I bring just Simon and Katja, I mean, Simon, I remember that one of your talks, and you said about you showed how to look at the optic chiasma. Is that reliable enough in this scenario, or would you still have this degree of uncertainty? And is this degree of uncertainty enough to justify termination of the pregnancy late?
I think there's 2 parts to the answer to that, Asma. The first is the imaging side of it. So we know that on axial imaging going down to the base of the brain, that we can see the optic chiasma. That's the first step. And then more recently published, if you rotate the probe and you bring the orbit into view, then you can track the anterior part of the optic chiasma. So there's the imaging side of when you see that, well, that brings a certain level of reassurance that from an anatomical perspective, that the anterior component and the optic chiasma itself are present. So in your face receptor, all the features of a single shared anterior monoventricle, absence of the CSP, corpus callosum present and looking entirely normal, and you extend to seeing the optic tracts and seeing those being present, that's reassuring. But Anastasia said, you can't assess the function. And in a sense, therefore, it becomes extremely challenging in counseling patients with regard to blindness. And like for many of these CNS anomalies, providing precise data on outcome, broadly speaking, for central nervous system abnormalities is extremely challenging. And septo-optic dysplasia is up there right at the top with them all. And the thing is that imaging is spectacular on them when you go to image them, because many of them you can get the axial sagittal coronal images and you can get to the point of demonstrating beautiful anatomy, sometimes even the pituitary, and you combine with MRI, but it's the neurologist who's left holding the hot potato in counseling the patients in terms of outcome. And it's an extremely challenging area.
Katja.
I wonder if Kasia Peters, who is a pediatric neurologist, is online and may maybe contribute to this discussion based on her experience. Kasia, are you there? I see her name, but maybe she's... because maybe it's a discussion that we can also continue in the afternoon when she will be there. So what I'm wondering, what is the value of the measurements in septo-optic dysplasia? Because there have been some measurements of the optic chiasma, of the thickness of the optic tracts proposed. I mean, obviously, it's a very, very rare condition, and I haven't seen enough cases to be able to report on my experience, but maybe other in the panels have. What is the value of these measurements, Simon?
Katja, I don't think there's sufficient data at the moment to say that a particular measurement of either width or length of the optic tracts is of value in predicting outcome. I guess the next step that I would move to would be, after ultrasound assessment on what I've just described earlier, would then move to MR and to see if MR can assess the presence of the pituitary, the optic tracts, and ensure there's not any evidence of a coexistent abnormality. I think that would be the next step, but I don't have any measurement that I would use in clinical practice which would help me gauge in terms of categorizing mild, moderate, severe, or presence or absence. To me, it's a subjective assessment of looking for the optic tracts in both 2D and 3D. I have to say, when I look at the 3D reported data, originally came out of the French group looking at 3D reconstruction, I find that actually extremely challenging. And I've tried going through the various planes and reproducing the images that they've used with 3D, and I find it in my hands it is actually not that valuable. I have to say that imaging at the base of the brain, looking at the optic chiasma and bringing in the orbits in view in a slightly oblique section starting off at the base of the brain, I do find helpful and allows me to see the anterior component. But to answer your question in short, no, there's no specific measurement that I find as a value. I don't think there's any data to support prognosticating on measurements.
And would you dare to reassure, excuse me, the couple if you see very clearly the optic tracts on the coronal view?
I think if you see the optic tracts, it brings an element of better than if you don't see them. That would be the first comment I would say. And the second comment with regard to, I was coming back again to what Anastasia says, it comes back to, I have no idea what the function is of those optic nerves, because we know that even in the scenario where you see those after birth, you have a baby, even when you have imaging postnatally, and then when you start checking during the first year of life, looking for signs of blindness may be present, yet all your imaging suggests that the optic tracts are present. So again, it comes back to the same thing, and there's difference between the structure and function. But Kasia, I'm reassured in a scenario to a certain level, once I see the optic tracts, I know there's a chance of sight in that baby versus the ones where neither the ultrasound nor the CT can see any evidence of optic tracts. I would worry about them less, but there's no precise figures that I can put to that.
Very nice. If I just ask Anastasia, I mean, I really liked your talk, and particularly, of course, that you have the new onset diagnosis of ventriculomegaly in the third trimester. Quite challenging, is it? Because you're near the end of the pregnancy, you're telling the parents, well, there's ventriculomegaly, we don't know how, what sort of the consequences, and you need to do some tests, and some of the genetic testing, of course, take time. So how do you actually counsel the patient when you say, let's say mild? I mean, severe is easy, straightforward, but if you have mild ventriculomegaly at 36 weeks and you go back to the anomaly scan, the 20 weeks, and the measurement was within normal range. For me, I think there are two questions. Number one, because we routinely measure one side of the brain. So was it actually the contralateral side, also the ipsilateral, and it wasn't, so you just maybe you see another side and the baby had that all the way through. Or actually it is new onset ventriculomegaly, and how do you diagnose this patient? And do you use the same figures as what we use when the diagnosis is made at 20 weeks?
Thank you, Asma. That's a very good and challenging question. Well, first of all, the assessment of, one ventricle or both ventricles. We all know that we should at least look at the contralateral ventricle. The measurement of it is not very always accurate unless you are in a perfect plane. You have completely specific plane of two hemispheres being the same size, and then you can measure ventricle. But otherwise, at least look at it. The challenge of third trimester, I completely agree that it's timing, and you don't have lots of time to play with genetics. MRI can be performed the same day. Understand what is potentially causing this ventriculomegaly, because if it's severe ventriculomegaly, something is obstructing this cerebrospinal fluid circulation, and the question is what. Neurosonography at third trimester, we know that it's very challenging. The head is low in the pelvis, and vaginal approach is not easy at all. So I would say MRI is very valuable in this scenario. Genetics, of course, if it's towards severe ventriculomegaly, I would definitely counsel patients to have it done as soon as possible to understand, again, what is the potential underlying cause. But I would more rely that if 20-week scan was completely normal with beautiful brain, that the underlying genetic cause is, I would say, is quite unlikely. It's an event in the circulation of the blood in the brain, stroke, maybe infection. Maybe that would be likely cause of ventriculomegaly in the third trimester.
Okay, that's great. Any other comments from the panel? I mean, Simon, do you have a different experience?
I think, look, I guess it depends on healthcare systems, Asma, as to how far and how you push the presentation of ventriculomegaly late in the third trimester of pregnancy. Different countries have different legislation with regard to changing the course of the pregnancy, and how far you would proceed with investigation would be very much dictated by that. I think, but you raise a very valid point, Asma. When you're faced at 35 weeks of gestation with the first time presentation of ventriculomegaly, how far do you go down the windy road, realizing that in a couple of weeks' time she's going to be delivered? And I think Anastasia made a very valid point is you're thinking more in the lines in the setting of having had a prior normal anatomical scan. You're beginning to think about running off a torch screen, looking for psychomenovirus infection, looking for basal ganglia calcification and hepatic calcifications, ascites. Yeah, so you're looking for markers of fetal infection as the third trimester events that have occurred. But, in terms of going down the pathway of offering amniocentesis, exome sequencing, fetal MRI, it's very, very challenging at that stage. And in a sense, for many of us very late in the pregnancy, it would maybe go to an MRI at the most. Late gestation, we would not be considering. It'd be too late to be running exomes, and then we'd be saying, wait until after delivery.
Okay, fantastic.
I would like to ask a question to Wendy regarding the position of the choroid plexus of the fourth ventricle. This has become a very fashionable item recently, both in the first trimester as also in the second trimester. So I would like to ask you how often and how heavily do you rely upon this new approach in making your differential diagnosis of posterior fossa anomalies?
Yeah, you're quite right. It is fashionably. In late years, I think it's really difficult. It's really challenging to look at the right position of the choroid plexus if you have an anomaly, because you always have to look in 3D, and you always have to have a cyst to look at the right position in the posterior fossa. So yes, we try to look at it, but if I have to counsel patients on anomalies in the posterior fossa, I more rely on the shape of the firmus, but especially how much tissue is there. And so if you have a really small firmus, then prognosis will be not so good. And if there is quite a normal amount of firmus, then I think prognosis is better. And of course, we offer all the patients genetic testing and MRI and all these things. But if I have to counsel patients, I think this is one of the most important things, because I still find it difficult to really rely on the images on the position of the choroid plexus.
And what is Simon and Francesco's view on this?
Look, I think there's a good paper, I think, that Dario has presented by looking at the position of there's first and the second trimester. Maybe I'll just comment briefly and maybe hand over for Francesco to give a more detailed answer about the second trimester. But I know Dario wrote a nice paper looking at the position of the choroid plexus in allowing you to distinguish between Dandy Walker malformation versus Blake's pouch cyst, and that it was more elevated and displaced superiorly in Dandy Walker. I think it's controversial. I think people, again, I don't know how much data there is out to, number one, support that. And secondly, in terms of acquiring those images, really requires very significant expertise and understanding of multiplanar analysis. I think I agree, in a sense of looking at the morphology of the vermis, as Wendy has said, is probably of primary importance in terms of trying to distinguish between the two. And that would be my comment about the second trimester. With regard to the first trimester, I think it has been underrepresented, the importance of the fourth ventricle and the choroid in the first trimester, and we're only beginning to understand what a powerful marker it is, not just for structural brain malformation, but for aneuploidies and microdeletions. So if you take those three groups, aneuploidies, microdeletions, duplications, and posterior fossa anomalies, and we've spent years looking at the fourth ventricle intracranial translucency on sagittal imaging, but we've, in a sense, lost the focus. We are now pouring the focus on looking at the fourth ventricle, but it's in the axial section, because in the axial section, you see the entire area of the fourth ventricle. And with experience and time, you get to understand with a reflex that fourth ventricle is enlarged. And we spoke about the diagonic triploidy, which is the standout example of the power of that marker, because we know that 90% of the diagonic triploidies, you will have a big fourth ventricle, which is so important in the first trimester because you have no other clues if you're running just your standard NIP, not SNP-based. But it's also not for that, because the other aneuploidies is really powerful, 18, 13, it's for 21 Turners, and I showed examples of these. But the point I make is, when you go to a first trimester and do a four-section analysis on axial section, you see the fourth ventricle in the final section and look at the whole area of it and measure it. And I think if you start getting a measurement anterior, posterior more than 2.5 at a 13-week scan, you know you're looking that something's going on. And if you look at the data that's published and the evidence to date, we're far more likely to be faced with the problem with a dilated fourth ventricle than we are with the reduced fourth ventricles of an intracranial translucent spina bifida. But the wealth of data we have on the small fourth ventricle is in stark contrast to the data or the potential the fourth ventricle has when it's enlarged. And I think that's why it's become of particular interest.
Can I just add something? Because I think that, it's a beautiful paper by Dario, but I think certainly in order to be able to see the choroid plexus of the fourth ventricle, you really need a multiplanar. And therefore, I think most of the old literature did not really take into account at all the choroid plexus of the fourth ventricle when you have a cyst in the posterior fossa. So I think you almost like really need to redefine, the literature when you're looking at, we take into account the choroid plexus and the fourth ventricle and how it helps us in the differential diagnosis compared to the old well-established literature. So I think it becomes really quite challenging. And the other thing which I learned recently, which is a case that the presentation was so different and differed so much with gestation. So it started with almost first trimester ventriculomegaly. So a lot of the CSF dangling, choroid plexus, big lateral ventricles, and then progressed to become no ventriculomegaly, but actually typical Dandy Walker. And with agents of corpus callosum, the open fourth ventricle, the absent vermis. So, and therefore, I think that's another thing is that as we are looking at the brain in the first trimester, and defining it better, I think you're looking at natural history, which was not really defined in the past.
Yeah, I
And
think so. I mean,
yeah,
Asma, yeah, go on.
No, so sorry, Simon. So keep on.
I think you're right, Asma. And I think if you actually go back to the very original paper by Ashley Robinson, who actually was the first to describe the morphological differences between them in a beautiful paper in a not a terribly well recognized journal, Ultrasound Quarterly. It was at that time, I think we all overlooked the importance of the choroid. And I agree, Dario's work is spectacular and his imaging is spectacular. But translating from that into routine clinical practice by measuring the position of the choroid, whether it's superior and inferior, in a multiplanar analysis, requires an enormous amount of experience. And it just is difficult to translate that into routine imaging for a common clinical problem where we're faced with that communication between the fourth ventricle and the cisterna magna. That was the point I make. I wasn't underestimating Dario's work in any way whatsoever. I'm saying it's controversial from the point of view. It's hard to translate. What I meant to say was it's hard to translate his work into routine clinical practice, what I meant to say.
Sure.
There's one question, Takachi, I think, in the chat about if there is no CSP, but there is corpus callosum.
To me?
No, I mean, I think just highlighting before we finish, I think maybe we should ask this question.
Okay, yes, please repeat it because
Okay, so I think there's one of the delegates. Could you tell what does it mean when the CSP, the cavum septum pellucidum, is not present, but actually the corpus callosum is normal? So when you don't see the CSP, but when you actually look at the mid-sagittal, you can see the corpus callosum and it appears normal. What's the workup and how do you counsel the patient? And that's probably relevant more to Francesco.
yes.
Yeah, but we already gone through that,
Yes.
and we all the different options, which are essentially to possibly rule out septoptic dysplasia, which of course is not always possible in most of the cases. And so can I add something briefly about position of the choroid plexus? Because I think that the problem with the position of choroid plexus is that it's something that has been reported in postnatal medicine. And prenatal diagnosis should adopt the definition which have been reported in postnatal medicine. So the new classification of posterior fossa, which have been released a couple of years ago, actually did not include the position of the tentorium, but rather the position of the choroid plexus of the foreventricle. And I actually do not agree on the fact that it's not possible to say it's possible to see that only on 3D ultrasound, because we have a huge experience in identifying these on 2D, and you can do that either on axial views and parasagittal view. Be implemented in the future in the guidelines. Cannot have a prenatal definition and a postnatal definition used.
So it's a shame that we haven't got the possibility of doing a live demonstration. Otherwise, you would show us very easily how you can get this. I have another question, because you said, Francesco, in your talk about corpus callosum, that we should be aware of when we use the color Doppler to image the paracallosal artery, that it could give some false negative diagnosis. And Wendy said a little bit the opposite. She said it's like when you have renal agenesis, if you see the renal arteries, it means that the kidneys are there. So how do we harmonize these two views?
Yeah, I think that we told the same, because what I told is that when we see pericallosal artery, we can say that the corpus callosum is there, and in most of the cases will be complete. What I told in my presentation, and I know that I told something controversial, is that if you think a radiologist, they do not use angio-MRI, they do not use contrast MRI in order to look at the corpus callosum. And why is that? Because the pericallosal artery follows all the corpus callosum except the most anterior part, because it does not encircle the rostrum of the corpus callosum, and partially the splenium. It does it at the splenium in most of the cases. So if we apply color Doppler, we can say that the corpus callosum is there, but we cannot confidently rule out the agenesis of the rostrum which of course is something so rare that so it occurs in one case every 5,000 cases of partial agenesis of the corpus callosum. I say that in most of the cases, if you want to demonstrate that the corpus callosum is present, although it is not recommended by the ISO guidelines of standard assessment of the brain, you can use that. If you want to confidently identify or rule out partial agenesis of the corpus callosum, you cannot rely on the pericallosal artery, because the only thing that allows you to completely rule out partial agenesis that we have to see the anteroinferior part, which is the rostrum, and the posterior inferior part, which is the splenium. And only the direct visualization allows to do that. And it's also demonstrated by the fact that the radiologists, they do not use so this technique to look at the vascularization to describe the corpus callosum. It's useful in 99+9% of cases. If you apply color Doppler, will tell you that the corpus callosum is present. But in terms of detailed assessment, the only things that allows you to rule out condition is to directly look at the splenium and the rostrum.
Okay, so very clear explanation. I thank you all, and I think we have now to go for lunch. It was a very stimulating discussion and very nice session. So thank you all, everyone, for replying, people for asking questions. And we will see each other at 13:45, 1 hour, 45 minutes. Have a nice lunch. Bye-bye.
Thank you.